Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, everyone. Welcome to another episode of the AMPT podcast. My name is Dhinu Jayaseelan, and I'm pleased to be joined today by Dr. Angie Fearon. Dr. Fearon is an associate professor at the University of Canberra. She completed her Bachelor's of Applied Science in Physiotherapy at Lincoln Institute of Health Science, her Master's in Physiotherapy at the University of South Australia, her PhD in Medical Science at the Australian National University. She's a long-term member of the Australian Physiotherapy Association, and she has a primary clinical and research interest in hip pain, specifically gluteal tendinopathy. Today, we'll be discussing her recent publication in BMC Musculoskeletal Disorders titled The Natural History of Greater Trochanteric Pain Syndrome, an 11-year follow-up study. Dr. Fearon, thanks so much for joining us today.
Thank you for having me. It's a pleasure to be here.
To start, for those who have read your study or those who haven't, can you start by giving us a recap of what your team did and what you found?
Of course. This study really started with my PhD in the early 2000s. At that time, I recruited 3 mutually exclusive groups of people. Those with end-stage hip osteoarthritis who were lining up for a hip arthroplasty, an asymptomatic group, and a group of people with GTPS, Greater Trochanteric Pain Syndrome. Way back then, I undertook clinical imaging studies, which meant we had a fantastic baseline for this cohort. Fast forward 11 years, and I pitched to the outstanding senior physiotherapy students who had the opportunity to do some research that while we knew that people with GTPS had high levels of pain and dysfunction, we didn't actually know what happened to them. Remember, the mean age of people in studies with GTPS or glute tendinopathy is about 55 years. So what happened to these people? Did they get better? Did it magically disappear? Did they all end up with hip osteoarthritis, as some people had suggested? Or did they all break their hips? We just didn't know what happened to this group. So a wonderful student, shout out to Luke Bickett, put up his hand and helped me with this work, along with 2 other colleagues. So after excluding those who had enrolled in the study with hip osteoarthritis or those who went on to gluteal tendon surgery, we gained a new ethics approval for the study and set about locating the previous participants who either had GTPS or were asymptomatic. Some people I still had contact details for, which made that a little bit easier, but others we had to search for. We had about 81% return rate, which was fantastic, and that comprised of 24 of the 31 people with GTPS who hadn't had any surgery and 20 of the asymptomatic people. Our primary aim was to determine the rate of GTPS and hip osteoarthritis in this cohort. We ran this group through the GTPS clinical diagnostic test I'd previously used and also clinical tests for hip osteoarthritis. We also did some post-hoc glute tendinopathy and hip OA tests, coming up with basically the same results. We then asked the participants to undertake the following patient-reported outcome measures for quality of life: the modified Harris Hip Score, the Oswestry Disability Index score, and a functional comorbidity index. That latter one looks at the number of comorbidities that people have that may impact on musculoskeletal conditions in particular. We also did hip abduction and external rotation strength, a 10-metre walk test, and a timed up and go test. These are all scores that I'd used at baseline. So what did we find? Of the GTPS participants, 9 had gone on to develop hip osteoarthritis, while only 1 of the asymptomatic group had developed hip osteoarthritis. 40% of the people with GTPS still had GTPS, and 1 of the asymptomatic group had gone on to develop GTPS. 25% of the GTPS group had other sources of hip pain, so we couldn't clinically diagnose whether it was OA or GTPS or a labral tear or something else, while 15% of the asymptomatic group had some sort of hip pain, but it wasn't hip osteoarthritis. 15% of the GTPS group had no hip pain at all, while close to 80% of the asymptomatic group had no hip pain at all. In terms of function, the differences seen at baseline in terms of quality of life and through the modified Harris Hip score had disappeared. The group differences had disappeared by 11 years. And there remained a small and probably not clinically significant difference in the Oz-Westview Disability Index. Interestingly, there was no between-group difference for strength, 10-metre walk test, or timed up and go at baseline or at 11 years in this cohort of the group. But I want to point out that we inadvertently measured these slightly differently at baseline compared to 11-year follow-up, which was unfortunate. So in summary, people with GTPS continue to have hip pain over an extended period of time, and that GTPS appears to be an unrecognised risk factor for developing hip osteoarthritis.
And then with your study, there's a lot of findings to kind of think through and unpack. But the first thing that struck me, even just reading the title, is that you were able to do an 11-year follow-up, which in our literature and the physio literature is just completely unheard of. So to me, first of all, kudos. Well, I guess to you, kudos, not to me. But can you explain, how did you make this possible that you can get this follow-up? And then also the benefit that we have in our literature if we can continue to have these longer term studies become published and pursued compared to maybe more of the short term, intermediate term follow-ups?
Yeah, thanks for that question. I'll preface this by saying that Luke, my student, was continually surprised when these mostly women would come to their appointments, and these were people that I hadn't seen for about 10 years, and they'd come up and they'd give me a big hug. And remembering this is pre-COVID that we did all this work. Importantly, he was unable to determine which person was a person with GTPS or an asymptomatic group, but it was not uncommon for them to, come into the clinical room very enthusiastically. So I think part of that was that as part of my PhD, I planned to do a 12-month review, and in fact did do a 12-month review. And thus, during the recruitment and the following 12 months, it was really important that I kept in contact with this cohort. So I did this by sending out regular newsletters and Christmas cards and the occasional phone call, so that over 12 months I had continuing contact with this group of people. And so they actually got to know me quite well, and I got to know them quite well. And also for the GTPS participants, remembering this is the mid-2000s, we didn't know as much about GTPS then as we do now. They'd found someone who could explain to them what was going on and who believed them, who actually believed that they had the amount of pain that they were talking about. And so I think that we had a resonance there. At the 12-month follow-up, I asked them if they'd be happy to be contacted again should we wish to do that, and they all said yes, which was fantastic. So in summary, I think it was the relationship I built up with them during that first 12 months that resulted in a really strong follow-up. And in terms of the importance of long-term studies, that they are so important for understanding what really happens to people over time. And they are frequently difficult to do because you've got to follow people and try and maintain contact with them. This really gives us very clear insight into cause and effect. So we use randomized controlled trials to understand cause and effect of treatment, but in terms of the long-term prognosis of a condition, there's really nothing better than a long-term follow-up. And that really helps us to understand these conditions that take a long time to develop, such as hip osteoarthritis. It's hard to fast forward something like that.
You mentioned developing a relationship was something that helped to maintain their interest. And I think that's one of the beauties of what we do in physio is we develop relationships and we get buy-in and people want to come back, partially because they get a therapeutic effect just from that relationship. But one thing in terms of therapeutic management over the course of your study, individuals were free to obtain a corticosteroid injection. and the utilization of those injections was tracked over time, were they allowed to get other treatments? And if so, was that tracked as well?
Yeah, that's a great question. We didn't control for what people did during that 10 or 11 years, largely because while I had asked them if we could follow them up at a later time, the original study was just for the 12 months. And so we weren't trying to control them in any way for the following 10 years. The other part about that is, I guess, a truly natural history would be to say, you've got this hip pain in this instance, don't do anything about it, and let's just see what happens. But as we know, this population have quite high levels of pain and disability, and that would be a bit unkind, I think. So it's a natural history study in that it's what people did naturally, I guess. So we didn't control for what they did, and we didn't actually ask them to refrain from any particular treatment. Unfortunately, we weren't able to accurately capture this, and that's in part because while people can usually remember if they've had a painful injection into the side of the hip, we did try asking this question, but they weren't very good at saying whether they'd had physio or exercise therapy of another sort, or Pilates or Reiki, or any other sort of massage therapy. They just weren't very good at remembering that over 10 years. So it would have been nice to have been able to accurately capture that, but it wasn't something we were able to do.
Yeah, and even if you did capture it, the benefit I find from the results of this study is that it's realistic, in that the more you control, sometimes the more it becomes less clinically relevant. But this is over the course of time, people were allowed to choose to do what they needed to do, but they still developed this problem over time. So I think there is a lot of benefit in that type of study. But one of the things we also noticed, or one of the things you also noticed in your study, was that a lot of the differences that were there between groups at baseline did seem to level out at that 11-year follow-up, even though the conditions might have been different. A lot of the baseline demographics, actually, even including BMI and comorbidities and quality of life, those things kind of leveled out, which was kind of interesting to see, especially for me, seeing the median BMI was not statistically different at that 1-year follow-up. You mentioned in the report that one of the potential reasons for this kind of washout was the Hawthorne effect. But I'm wondering, what else do you think could have played a role in these results kind of being equivalent in so many ways?
Yeah, that's a really great question, and something we puzzled over for a little while. So in the results section, you can see, at baseline, the BMI, there's a difference of 3 units approximately at baseline, and then, as you say, just about, well, it does disappear by the 11-year follow-up. And part of this is, as I noted, probably the Hawthorne effect, so that we call it a Hawthorne effect, but maybe you're right, it was the relationship I developed with them, and may have had an impact on them. But the GTPS people lost some weight, and the asymptomatic group got a little bit heavier. So I think that explains the BMI difference, in that maybe they're just reverting to the mean in both groups. So the other thing that is worthy of note is that the GTPS group actually got a little bit healthier as well, whereas the asymptomatic group maybe succumbed to a few more age-related issues, because their comorbidities, that functional comorbidity index, also changed from being a significant difference. So at baseline, the GTPS group had 3 comorbidities compared to the asymptomatic group, which only had 1, whereas at the 11-year follow-up, they both had 2 comorbidities. So I don't think that's the Hawthorne effect going on there. I think that's probably the GTPS group maybe becoming a bit healthier, and the asymptomatic group becoming a little less healthy as they've got a bit older. So when I was doing this assessment, both groups of participants had 2 hours with me at baseline and then 2 hours with me at the follow-up. So they had a fair amount of interaction with me. And while I wasn't providing any specific education in a research format, you chat to people about what's going on in their lives, and they invariably ask you what they can do to help the situation. And it wasn't a randomised controlled trial, so I was at liberty to give them some advice, which wasn't necessarily based on any research because we hadn't done any at that point in time, but a lot of them were overweight as per the BMI, and it made sense to suggest that they try and lose a bit of weight and improve their activity level. So that may be what we're seeing coming through there. The other thing to remember is that nearly 15% of the asymptomatic group had developed hip pain, so maybe they'd reduced their activity level.
It's important for me to kind of, when I'm processing research, to kind of think about all the findings in the contexts of the strengths and the limitations. For me, one of the main strengths is the long-term follow-up. I think it's a strength that you had some baseline imaging to confirm that individuals didn't have signs of OA, to then be able to say some people did actually go on to develop clinical OA versus some people didn't. And then you also listed explicitly the limitations of the study, which I appreciate, and you're upfront about that. But I always want to make sure that we're clarifying and not misinterpreting the findings. We can't really say based on the results of this study that those people that had GTPS will go on to develop hip OA. Is that correct?
You're correct in that there are some, great strengths, the duration, and some limitations. It is a very small study by epidemiological measures, but it's an important one all the same. I think we can be reasonably confident in saying that people with GTPS or glute tendinopathy are at a higher risk of developing hip osteoarthritis. That doesn't mean that they necessarily will, but our data our data shows us that they have twice the odds of developing hip osteoarthritis than an asymptomatic group. So it's not a certainty, but we're pretty confident that they are at a higher risk. Now, I will acknowledge that we didn't use radiology to confirm our diagnosis at the 11-year follow-up. In hindsight, maybe we should have, although diagnosing hip osteoarthritis in this age group is not difficult. And we did do it in two ways to do a sort of cross-check on that diagnosis. Adding X-rays probably would have increased the number of people with hip osteoarthritis in both groups, but proportionally by about the same amount. It certainly wouldn't have reduced the rates.
Yeah, it's interesting to think that if you have GTPS, there's a higher risk of you developing hip OA, because a lot of our MSK conditions, if somebody develops pain somewhere, our best evidence really big picture says, stay active as possible, modify activities as necessary, get stronger if something's weak, stretch something if it's not moving as much. But more often than not, natural history will actually kind of manage most conditions from an MSK perspective. And GTPS, it's starting to make us think that maybe this isn't a self-limiting condition, but actually leads to other secondary conditions. And it wasn't necessarily something you studied or something that was a purpose of your study, but I know you have some expertise in it. And there have been some studies suggesting GTPS could be associated with impaired central pain processing. I wondered, what are your thoughts on altered nociceptive processing leading to the persistence of a condition like GTPS, or even predisposing someone to the development of a secondary condition like OA?
Another excellent question. So I think in any condition, musculoskeletal or otherwise, where there's a long-term pain presentation, the long-term nociceptive stimulation can often result in altered processing of the nociceptive input. So it doesn't probably matter whether you've got back pain or GTPS or an ankle injury or Achilles tendinopathy. When you've got a long-term stimulation, you're going to get some changes in the brain, and you're going to possibly get some changes in the spinal cord as well. So those are all things that we need to take into consideration. And possibly circling back to a question earlier you asked about why some of the differences we'd seen at baseline had all but disappeared at the 11 years, and some of them at the 12-month follow-up, may have been because they'd come to see me and I'd kind of reassured them that, not intentionally, but I'd reassured them that they didn't have anything really terrible going on with them. And we know that by providing people with accurate information about what's wrong with them can help them understand that naturally, and also reduce any catastrophizing they might be having. You mentioned earlier that I have a clinical interest in hip pain, and I still work half a day a week in the clinic. And often what I'm saying to people and helping them understand is that no, they don't have cancer, and that this is a manageable condition, whether it's GTPS or something else, and giving them some tools to manage that. And just by talking to people, you don't even have to lay your hands on them. You can reduce their pain levels from 6 out of 10 to 3 out of 10. And I see that quite frequently. I think there can well be some altered nociceptive processing in this group, but I think physiotherapists are in a perfect position to help people normalise that processing.
And to that point, admittedly, you had a relatively small sample, which, again, it's hard to get large samples to track over time, but there was enough people in each group to give us some confidence in the results. But let's say this were replicated, hypothetically, let's say this were replicated with the bigger study, let's say 300 people in each arm of this study. If we note a trend of individuals with GTPS having the condition long-term, and we know some might go on to develop hip OA, given your kind of role as a clinician, as an educator, as research, what priorities should we be having now for this group that has GTPS, do you think?
We need to continue to look for and test comprehensively treatments for this group, treatments that address the underlying impairments, not just the pain. So I'm not sure about in the States, but in Australia, the first line of treatment for these people is often to have a corticosteroid injection. They'll go to their general practitioner, their local doctor. They go with hip pain, and despite the fact that we know that exercise can produce some really good results with this cohort, they're still given an injection which will provide some good, some really good short-term pain relief, but it doesn't address the underlying impairments. We know from the LEAP study that was done by the Queensland and Melbourne people here in Australia that exercise and education can really help this group of people in quite a short time frame, like 2 or 3 weeks, and that helps over time. But that study had very intensive study, so probably not something that is easily replicatable for the local physiotherapy or physical therapy practice. For clinicians, ideally, I think you need to undertake a really comprehensive history and clinical exam and address the various impairments that you find. In GTPS, or glute tendinopathy, this is particularly important as I find that each person has their own fingerprint, if you like, of impairments. No one person is exactly the same. What we haven't talked about is whether there's a proprioceptive impairment going on here that hasn't been fully explored. And unfortunately, I didn't win the large amount of money I wanted to have to follow this up, but maybe that will still happen. But I would suggest for clinicians that, you can do that on an n=1 basis. The person in front of you is the person you want to treat. So have a look at their strength, have a look at their proprioceptive impairments, think about what their beliefs are about their pain, think about what their understanding is about what they can and can't do, and really help them find ways to keep exercising that don't continue to irritate the tendon. In terms of researchers, I've just alluded to the fact that I think there's probably a role for some proprioceptive investigations. There's a little bit of research out there suggesting there's some changes, but we need to do a little bit more work in that area. And then we really need to get into looking at some additional treatments. If you think about how much research has gone into treating Achilles tendinopathy, you can write systematic reviews just on whether it's eccentric or concentric exercises that work for Achilles tendinopathy. And yet we've only really got a handful of papers on treating gluteal tendinopathy or GTPS. You notice I keep switching between the two. In most cases, GTPS is primarily gluteal tendinopathy plus or minus a bursitis problem. And so for researchers, I think we need to sort out the proprioceptive issue, but also get onto some additional treatment research to provide clinicians with excellent research-based treatments. And for educators, I think it's important that they teach their students well. That sounds self-evident, really, doesn't it? But and I'm not sure about in the States, but in our little university, we don't really have time to go through each individual tendon at the undergraduate level. But helping students understand the importance of load management, of pain management, and that talking to people about their pain, and really finding out the individual person's impairments and addressing those would be my key tips there.
And I appreciate those tips because it seems like every time we have a research study out, it kind of guides us into the direction we need to go. But with our profession, it really does come back to listening to what the person in front of us is telling us and really reassuring them. In most cases, these aren't red flag conditions and it's going to get better. And in this case, a lot of things did get better over time, but it actually, in some cases, led to a secondary problem. So I think it really is beneficial to see a study like this to come out. I wish we had more of them, and I'm looking forward to more of your studies coming out. And it really guides us in the long-term prospective perspective of some of these conditions, and which will help to make the education of the management more effective and help clinicians get more tools to guide their treatment strategies. So I really do appreciate you spending the time with your student and your colleagues to put this paper together and publish it. And I really appreciate you taking the time to chat about it as well.
Oh, thank you very much. It's always a pleasure to talk to people about hip pain and, hopefully provide some guidance for people. We're all in this profession to help others and to improve people's quality of life. So if I've contributed in some small way to that, that's fantastic.
And to that end, actually, what we do is we typically tag our participants' kind of contact info in the show notes at the end. So if our listeners have questions, can they go ahead and reach out to you to discuss this a little bit further?
Yes, and I'm on Twitter, although I'm not quite as active as some other people. So at Angie Fearon.
Sounds good. So Dr. Fearon, thanks so much for spending the time to chat with us today.
You're very welcome. Good night to you and good morning to me.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.